us in the room.
If you just let people in, Jess, I will ask them to announce themselves and their location.
Sounds great. Thanks. I've got to mute myself now.
Hi, Christine.
Hey guys, how's it going?
Wonderful.
Good.
How are you?
Good.
Let me just introduce my husband. This is Gary Stoner. He's OBGYN, so he's just gonna sit in. And Nick, if you need any backup, or Christine, if you need any backup, just give Gary a shout. It's gonna be a fly on the wall, and just
Perfect.
you need him, okay?
I appreciate you being here. That's a great idea.
All right, thank you.
I can't remember the last time OB offered to help and I said no. So
How true, how true. Win?
Yeah, hi.
hi.
I'm coming in from Houston, and I'll just be a fly on the wall, just observing. And my doctoral student is joining right now, Nahid, and we're
Okay.
talking. I'm working with Manoj, and we're just trying to hear all the stories. Your regular.
Okay, all right. Yeah, I'm a co-founder of Techies with Manoj and the medical director for Techies. Just helping
Excellent.
out with Journal Club today. So.
And I'll be coming out to Sydney. I've already booked my flight, so I'll be out around November 7th or 8th is I believe when I'll be for a month. So to continue thinking about all the issues around this.
did I successfully share a slideshow or the background?
Where did my chat go?
Can you guys see the slides?
No, we're looking at your WhatsApp chats, I think.
Oh, that's awkward. How do I?
There you go.
I even clicked to share this one.
Yes, that's the slides.
Yay.
Yes.
And then also pull WhatsApp back up.
Deb, my boss just showed me how to make you the host, so you should be host now.
Okay. All right. Thank you.
Thank
you. This button.
All right, so I need to.
You're probably not looking at slides anymore, are you?
No, now we see your Google search.
Dang it, man. Struggle bus. There's always room for one more on the struggle bus. In this office at work, I have access to like the ability to plug in my laptop to dual monitors, and it's awesome, but I haven't necessarily figured out how to navigate it with screen sharing yet.
Oh, Deborah, you were asking the chat. Nahid just joined. He's my doctoral student at Houston as well. So, and you're muted, Deborah. So.
Yes, okay. Nahid, that's fine. You can just announce where you're from. It helps with our attendance.
Thank you. My name is Naidu Sai. I'm a doctoral student working under the supervision of Professor Win Chin in here at the University of Houston. We are working in a project for one of the papers of our dissertation, and that's why basically we are in here. Thank you. Nice to meet you all.
Welcome. Thank you for joining us.
You too.
And just to add a little more color, because of exactly this technology you're doing, our area is indeed on knowledge management systems and looking at both how people, transferring knowledge and gaining knowledge and all that, which seems to fit really well with the CMES.
Now, are you looking at slides?
Yes.
Yes.
I'm a really good guesser. I just need enough guesses. All right.
Nick, are you just waiting for participants? I haven't seen anybody pop up to
Yep,
be
just
added.
yeah, no, I'm just waiting for people. I am curious though, since we do have an OB-GYN on here. I don't know, Gary, if you've listened to one of the more recent MRAPs, but there was a case of uh a peripartum arrest with a clot, and the question was resuscitative hysterotomy and or TNK. And it's a really interesting discussion, especially because the idea that if you give TNK, you're supposed to continue resuscitating for a while before like calling treatment failure on the TNK, but you're also supposed to have baby out within 5 minutes if you're going to perform a perimortem C-section. They didn't have any OB-GYNs on the section, but I'm really curious to see if you have any strong thoughts about it, or would just rather pass.
Wow. Yeah, boy, I've never been in that situation.
Right?
Yeah, boy,
Because I
like
don't even
Gresham,
know how feasible a C-section would be with that much bleeding. Like, I don't know how hard it would be to even see, like, how obstructive it would be for the process of a C-section.
With so
So-
C-section or clot buster med.
Or both.
yeah, I don't think you'd have time to wait for a clot buster.
Exactly, yeah.
Yeah, you'd what gestational age are we talking here?
I think they were at 36 weeks in the case, I think.
Oh, wow. So we
Viable.
have a very viable baby here.
Yeah.
Yeah, and I've seen this happen where I had worked. It actually happened in the emergency room. I was not involved with the case, but it was sort of a post-mortem C-section.
Mhm.
And yeah, I think, if you have a severe clot that has put the woman in arrest, you just need to get the baby out, particularly when
Yeah.
it's a viable baby. And then once the baby's out, do whatever resuscitative measures you can for mom. But boy, that's
That's
that
an
is
interesting
nail biter.
point too, because
Sorry.
that's an interesting point because I think they were talking about the idea of doing both, right? So you'd give the thrombolytic and then perform the resuscitative hysterotomy. And but also it's being said by people who have never performed a C-section, right? Or at least not experts at it, even if they have done one or two. But because the idea of working a resuscitation for 30 more minutes is not consistent with saving baby. But if you can get baby out in under a minute or two, could you then give thrombolytics and try and save? So now you've secured baby, so baby's now safe, and then you have a chance at saving mom too. I don't know. I don't know. It's
Yeah.
a possible situation where there's no right answer, but
No, you're right. To get the baby out quickly, you got a lot of bleeding coming from everywhere, and now you're going to give a thrombolytic
yeah,
on top of that. It's
sounds like a horrible idea.
Just pack. Get baby out and just pack the heck out of it.
If you
Yeah.
if you took out the uterus, like how much, like if you did a hysterectomy with it, how much bleeding is there outside of it if you've removed the uterus?
Well, my first thought is, where is the mother? Is she sitting in the emergency room at this point? And do you have the equipment in hand to do a C-section with the clamps and the retractors that you need? That's going to take time to garner that.
No, every emergency department has an emergency C-section kit ready to go.
All right. Well,
we have a C-section tray down there. To be fair, I've never opened it. So I don't know if it has what I need in it or if it's supposed to have what I need in it. But
Nick, can I interrupt you for a second?
Sure.
Is this unusual to have people come in this late? My concern is that the requests are still going to Jess, although I'm host. I haven't seen anything pop up for anybody asking to be let in.
It is unusual with the sickle cell acute chest one. There was very few, like I think one or two participants, but usually we get up to, I feel like 15 to 30.
Mhm.
But I think that the one that just did with sickle cell was just an aberrancy.
Okay,
Or
all right, I'll just keep watching here. Sorry to interrupt that discussion. I just want to make sure I didn't miss anything.
I'm like the classic case of Dr. Glockenflecken, where like when a consultant's within eye shot, like they're gonna get asked questions. Then I'm curious about.
Well, if you have any questions on opioid use disorder, that was actually Gary's specialty at the end of his career. He closed his career out with opioid use disorder in pregnancy.
Interesting. That's really interesting.
That's so interesting. What was the kind of recommended intervention?
Treatment.
Treatment, boy, that has to be case specific. That's sort of a blanket question that to which the degree of answer requires sort of knowing what the situation is.
Yeah.
I guess the overriding thing that I dealt with the most is the elimination of stigma toward these patients, which is a huge problem. And that's where a lot of my focus was in the management and talks that I do about the stigma of this disorder. But, you know, everybody comes in to the system with a different degree of addiction and where they are in their process and their willingness to change and want to change. And boy, it's just a case by case. The answer to that is really a case by case situation.
Which stigma did you address more? Like stigma from the healthcare providers, from the community, fear of stigma?
Yeah, both. Yeah, healthcare providers, you know, they chose this. This was their choice to become addicted. No, it wasn't. A lot of trauma involved, a lot of people trying to escape their problems. We're all trying to escape something on some level. And to the guilt that comes with being an addict and carrying a baby. The irony to me is that that is really the opportunity to help a woman, a pregnant woman who has a substance use disorder to turn them around. And it just has to be done very non-judgmentally and with a tremendous amount of compassion because they feel so guilty of what they're doing. But changing behavior is difficult. And just, you know, name your demon, you know, drugs, alcohol, tobacco, procrastination, looking at your cell phone while you're driving.
I'm working.
So, you know, you got to just understand where that patient is.
I like that point. Especially I haven't had too much of it with pregnant patients in the St. Louis area here, which I think part of it's probably because a lot of those patients go directly to our Women Assessment Center. And so it's not to say that the population doesn't exist here, but a different part of our team tends to manage them more. But when I treat patients with a history of opioid use disorder, a lot of times in the emergency department, I open it with saying something to the effect of like, hey, I know ER doctors tend to be really bad at treating pain in people with a history of opioid use. I want to make sure you know that I want to try and treat your pain to the best of our ability. And I want you to let me know when you're in pain. Because like I know I can't get you pain free, but I want to make sure we reduce the discomfort and really try and meet you where you're at. And I remember there was one in particular, he'd actually had a thrombosis of one of his palmar arteries. So he had a ton of pain in his fingers. And initially when I saw him, he said he didn't have any pain. I think he denied drug use, and then I like saw his chart and it was just like through his chart. And I went back and said that his fiance was in the room. She's like, thank you for saying that. Like he's actually in a lot of pain and he was just really scared to tell you because he was really worried he was going to get labeled as a drug seeker. And so I found a lot of times just like addressing it like head on, you get very different rapport and very increased ability to treat people.
The really neat thing that Gary does is when he's even though he retired last year, he still gives a lot of talks and lectures and participates in community events, both up and down the East Coast and locally in Pennsylvania. And his patients talk with him, so they join him and they're able to share
Oh.
their stories.
That's awesome.
Okay.
That's really cool.
All right, we have someone. Here we go. Great.
Yay.
Let's see, Mohammed. Okay.
I'm surprised. Usually like Booba or Faith or some of those
Let me
people are
trans-
pretty good about
yeah.
them.
Just join me.
Mohammed. Chat.
Welcome, Mohammed. Let me check.
Oh, Faith. Okay. Great. All right.
Oh, Faith's here. Sweet.
Faith is here.
Welcome, Faith.
Hi, good evening.
How are you doing?
Good, good.
Good. Where are you coming in from?
Dr. Debra, I think you sent me a message that you intended to send to Faith.
Oh, did he? Okay.
All right, well, we got a couple people. We can get started. So Faith, Mohammed, thank you so much for tuning in today. We might get a couple people joining along here, but feel free to participate as much or as little as you want. We always like these to be interactive because we think one of the big benefits is information exchange. We don't want this to be us telling you what the right answer is, because A, that would imply that there is one right answer, and B, what works in certain settings might not be what's best in other settings, and C, there's a lot we have to learn from you all as well. But so feel free, if you're able to type questions in the chat, answers in the chat, feel free to unmute and speak up, whatever floats your boat. All right, and so for we're gonna start with an opening case here. So the case is a 25-year-old female presents with abdominal pain and foul smelling vaginal discharge. Vital signs are notable for a temperature of 40 degrees Celsius, a heart rate of 120, a blood pressure of 108/72, a respiratory rate of 22, and an oxygen saturation of 95% on room air. And what I kind of want to start with is knowing what some of your initial thoughts are when you hear this, right? If a nurse comes up and tells you this patient arrived, what are some of your initial thoughts? Oh, Faith, you coming in from a zoo? And welcome, Mohammed from the Gambia. Oh, sweet. And also, if I recognize I have a very thick American accent and I talk really fast. So if you can't understand me, feel free to speak up and let me know. I'm happy to slow down and repeat myself. Sometimes I just need reminders. So there's a wide range of things that could be going on with this patient, right? first we have a person with abdominal pain. There's a wide range of things that can be on a differential for that. And then a female patient also has has various female specific factors. And so when we think of this foul smelling vaginal discharge, that might broaden things or narrow things in certain ways. But one of the things I kind of want to point out is if we change it slightly, so it's the same scenario, but I added the line accompanied by her husband and 2-day-old baby. That this can really change how we perceive this patient. And we want to make sure that when we take a history, we don't want to get biased by necessarily, or we want to minimize the bias of what we first hear when we hear about this patient coming in, and making sure that we're receptive to new information. And I remember, especially early on in my training, I often thought of like pregnancy to me as a healthcare provider is scary, right? Like there's so many things that can go wrong. You know, I don't see it a lot. I'm not intensely trained in it. And I think of delivery as the end of my like medical provider pregnancy related problems, right? You got preeclampsia, baby's delivered, we're fine, right? Like, oh my gosh, there's D cells, baby's delivered. All right, we're in the clear. But that's not the case. And one of the things that I think one of the MRAP episodes recently pointed out really well is that we really need to make sure that we're considering pregnancy-related changes well after pregnancy. A lot of times people might think of the first couple of days, sometimes even up to the first 6 weeks. One of the things that they're starting to suggest is that we should really be being cognizant of this for the first year after pregnancy. And one of the cases that was mentioned was there was a patient where they were having trouble kind of figuring out what was going on. And they realized on the patient's phone, they'd had a picture of their brand new baby at home. And they're like, oh, is that your baby? And she's like, yeah, I delivered like last week. And then all of a sudden, your whole dynamic in the picture changes. And so this is one of those things where you want to make sure you're keeping an open mind and not just taking the information that's presented to you, but also making sure you're eliciting that broader information to get the context of the patient, because now we have postpartum changes that could be at play here. So today, well, we kind of described this as peripartum. What I wanted to focus on is a couple specific issues, because we can't do all of OB-GYN in an hour by any means. And a lot of times I feel like it's much more common to get talks on placenta previa, placental abruption, and things like that. So I want to try and focus on something that might kind of just change your perspective a little bit and kind of shine some light on some stuff that might get a little less attention. And so the three we're going to focus on today are postpartum hemorrhage, endometritis as it relates to the postpartum period, and preeclampsia. Welcome, Booba.
Yeah, thank you, Nick. Thanks, Nick.
You're welcome. Coming in from the Gambia, if I remember correctly. Is that right?
Yeah, that's very true. That's very true.
Welcome, welcome. So one of the cases we want to kind of introduce is this 29-year-old female who has a spontaneous vaginal delivery at 39 weeks at the end of her first pregnancy. There's approximately 1 liter of blood loss and blood still coming out of the vagina about an hour later. You notice vital signs of 110 for a heart rate, a blood pressure of 100/60, a temperature of 36 degrees Celsius, a respiratory rate of 18, and oxygen saturations of 96% on room air. And again, we're going to kind of start with what are some of your immediate thoughts when you hear this prompt, whether you're looking at the computer, trying to do some chart review before you walk into the room, whether the triage nurse comes up to you and tells you that this is what showed up. What are some of the first things kind of going through your mind here? So I know for me, one of the things that I think of is a liter is a lot of blood, right? And so now to be fair, delivery can involve a lot of blood loss, but you kind of got to think in your head on what's your thresholds for normal and abnormal, and what's acceptable and what's unacceptable, or what requires intervention and what doesn't. And one of the things I think is really interesting, which I thought about doing, but I realized I'd probably make a mess, is how much a liter actually is. So like we often think about like a water bottle, right? This is about half a liter. But if you actually took a liter of fluid and poured it on the floor, it is a much bigger mess than a lot of people realize. And so it's easy to kind of downplay just how much that really amounts to. And especially when you think that an average person might have 5 liters of blood in them to begin with. That's a 20% loss of their blood volume. And we're still losing blood, right? One of the things I like to talk about when it comes to bleeding control is, do we have anatomic control of hemorrhage, right? So in sure you pack, you put a tourniquet on or whatnot. But for me, as a non-surgical person, the scary ones are the things I can't push on, right? The GI bleed, the postpartum hemorrhage, gunshot wounds to the belly, chest, things like that. And so the things that are catching my attention here is, sure, okay, things might have been going well. I had a full-term delivery, but we have blood loss here, and we're a little tachycardic. I don't want to brush this off here. My blood pressure, I can live with that blood pressure. Oxygen, I can live with that. Respiratory rate, I can live with that. Not febrile. But one of the things that's catching my attention is how much blood loss we have. And so this kind of is to introduce the idea of postpartum hemorrhage. And there's various different ways it can be defined. It depends on which source you're looking at. I believe the American College of Obstetricians and Gynecologists describe maternal hemorrhage or postpartum hemorrhage as blood loss 1 liter or more, or blood loss with vital sign changes within 24 hours. Previously, there used to be much more attention to vaginal versus cesarean delivery. So vaginal, they'd say if it was more than 500, you want to be worried, or C-section, you want to be worried about 1,000 milliliters or more. But it's kind of simplified to, do you have a liter of blood loss or more? But then they also pay attention to the idea of blood loss with vital sign changes within 24 hours, because the first definition assumes you have identified all of the bleeding, right? Versus bleeding that's still internal or into a space that's not draining out. And so it wants to recognize if you have a suspicion about bleeding and you're seeing vital sign changes consistent with it, you want to watch out for it. Interestingly, when I was looking into this, there's a bunch of predictive models that they've looked into to try and predict who's going to be a high risk for significant postpartum hemorrhage. And basically, I think it was a Cochrane review, said there's not a lot of great work applied to the general population worldwide, a way to tell who's going to be at high risk. But there are some features that are really high risk for needing massive transfusion protocol. One is abnormal placentation, placental abruption, and severe preeclampsia. These all had an adjusted odds ratio of over 10 of having the requisite for massive transfusion protocol in the setting of postpartum hemorrhage. And one of the things I think is big here, this kind of circles back to what we were talking about last month on mass casualty incidents, of you want to have a plan in place before this starts. And the idea being, the worst time to try and figure this out is when the emergency is happening, right? And the big thing too is you want to practice it. You want to know that that equipment's there. So before this started, we were actually talking about a really crazy case we heard about. And the idea of, okay, what resources do I have that I can mobilize? And I think of an example we had a while back where we got a notification that there was a delivery in an ambulance, a spontaneous vaginal delivery in an ambulance at 27 weeks. And the infant was getting CPR. And so we're getting ready for this very high risk arrival of a potentially sick mom and a very sick child. And our plan was the Ohio table, like the baby warmer with all the stuff that you resuscitate a baby on, is supposed to have all of our airway equipment on. So you're supposed to pull the sheet off, and there's supposed to be all the things you need under the sun. And I remember we wheeled it in, and I pulled it off, and there was nothing. I had no laryngoscope blade, nothing. The smallest laryngoscope blade I had in the department was a Mac 3. And I was like, that is not going to work for a baby about this big. And so one of the things that I do now is every time you hear this, like, they'll be like, oh, I'm like, where's this equipment? And like, oh, it's in the cart. And I was like, I want to see the equipment. So making sure you have that plan in place beforehand, or like if you need to do a resuscitative hysterotomy or perimortem C-section, depending on how you define it, do you have C-section equipment available, right? How much blood do you have available for postpartum hemorrhage? Do you have tranexamic acid? Do you have oxytocin? And so I remember one time I was teaching abroad and we were talking about nitroglycerin for chest pain. And they're like, oh, that's a great plan. And then I think it was the next week they had a patient present with anginal chest pain. So they went to go find nitroglycerin. And this isn't a big ER big study. And they couldn't find any. So they were like running around trying to find the cardiologist to try and find out where the nitroglycerin was. And so you need to have a plan and you need to know operationally how you're going to do it. I'm curious, does anybody know their postpartum hemorrhage plan at their institution? Admittedly, I must say that mine is largely like call OB and say, please hurry. But for me, it's going to be talking about tranexamic acid, oxytocin, blood products, stabilization. Since we have obstetrics in-house 24/7, actually a team of them. But one of my favorite sayings is, if you want to give God a good laugh, tell him your plans, right? So that doesn't, just because we have them in-house doesn't mean they're not already busy with other patients. So I think I was talking to one of our OB-GYN chiefs the other day, and she was saying on their labor unit, they're responsible for like 50 patients, like their team is. And so a couple of those could be busy at once, which means if your plan is have OB come rescue me, but OB is already rescuing somebody else, you have to be ready to handle it in the meantime. So oftentimes one of the introductions that they talk to with postpartum hemorrhage are the 4 T's: tone, trauma, tissue, and thrombin. So tone, the idea is uterine atony. And so one of the things we can do about this is the bimanual uterine massage. So this is a lot of pressure on the uterus to try to encourage the uterus to contract down to help with that blood loss. And also oxytocin can be administered. Trauma, so this is, if you have big lacerations or hematomas, these can require repair, but this will help you get that anatomic control of hemorrhage. If you have uterine rupture, I really hope we have a surgeon around. But that's going to be another way we're going to need aggressive anatomic control of hemorrhage. Tissue, if you have retained products of conception, this can cause continued bleeding, right? So I think a lot of times in emergency medicine, we tend to think about the emergency. It's like, okay, the delivery's done, baby's doing okay, mom's doing okay, placenta's out. We think we're in the clear, right? And we think we're really good at checking the entirety of the placenta to make sure there's no bits left behind. But if you think about how many times you've actually looked at an abnormal placenta to know what that looks like, versus, oh yeah, this looks like the ones I'm used to looking at, but you don't actually have a good range on what normal versus abnormal looks like, you might have missed something. So you got to recognize that there might be some pieces retained. The other thing I think that's big here is a placenta accreta spectrum. So do you have placenta accreta, increta, or percreta? Because that's going to, that needs, to my understanding, surgery to be resolved. And otherwise you can have very severe and persistent bleeding. And then thrombin, a lot of times I'll talk about DIC or even just inherent coagulopathies. So you want to think about, do you need to replace coagulation factors? Now, one of the things I think is interesting too is there's so many different ways we can go about this. And in preparing for this, I actually came across the emotive study, which was published in the New England Journal. And I think it was mostly African countries. I think it was South Africa, Nigeria, Kenya, and should I have it up here? Tanzania, where they studied a lot of patients with postpartum hemorrhage, and they kind of came up with this acronym. And I like a lot of these frameworks because the heuristic can give you a starting place. And when I think of these things, I often like to say these guidelines are not to replace your decision making, right? I think one of the things that separates clinicians from technicians is technicians have a very much if-then kind of dichotomy oftentimes, right? It's like when I was an EMT, it was, if this, do this, if this, do this. But at higher levels, it can be much more nuanced and context specific. But a lot of times these are great starting points. So ACLS, or advanced cardiac life support, might be a great starting point, but it might not be the highest level of care that can be provided. Advanced trauma life support might be a good starting point, but it might not be the highest level of care that can be provided. But a lot of times this will help us get started in the right direction while we're getting our feet under us, trying to withhold panicking externally, and so forth. But so one of the things they start with is early detection and trigger criteria. So one of the things that they talk about is a calibrated drape to collect the blood. And this is the idea that it's really hard to estimate blood loss by looking at it, especially if it's on the floor or things like that. And so the drape is actually supposed to be calibrated with like markers, just almost kind of like you think of a Foley bag that'll have markers on it to say how much blood is lost. And so that way you get a better framework for how far behind you actually are. And then depending when you reach certain markers, that can trigger certain alarms, whether that's just notifying the team that you're at X amount or potentially starting an intervention. And so they talk about what are your trigger criteria going to be if you have blood loss of 500 mils or 300 mils with some other abnormality. But one of the first things you can do is that uterine massage to help with contraction and really get to contract down to kind of self-tamponade, if you will, some of the bleeding. Oxytocin is a great, I want to say maybe a level A recommendation, but this is often a prophylactically to help prevent postpartum hemorrhage. Tranexamic acid is really big, 1 gram of IV tranexamic acid given over 10 minutes. IV fluids. And I think one of the things I think this is one of those things that gets really context specific. Specifically for trauma for me, I tend to have very strong feelings about IV fluids, right? So if we're saying that this person's lost blood and that's why they're having difficulty with perfusion, right? Blood carries oxygen and carbon dioxide, helps with your gas exchange. IV fluids don't. So I can fill up the tank and make the numbers look nice for me, and that makes me feel good, but it doesn't necessarily address the underlying problem. And when you worry about coagulopathy, the pH of normal saline is 5.5. And so you're giving somebody a really acidotic fluid when you want them to stop bleeding, but acidosis can make it harder for your body to control bleeding. And so this is one of those things where it's good to have a plan in place with your team ahead of time based on how much blood products do you have, what kind of blood products do you have, how much IV fluids do you have available to make sure you're titrating these appropriately for your specific context. And then examination and escalation. So want to make sure the bladder is empty, evacuate clots, check for tears, and make sure that the placenta is complete and obtained outside of the patient. But then know what your escalation criteria is, and then what that's going to look and what your triggers are, and what those next escalating steps look like. They also talked about, and I'll include the citation in the notes afterwards. So if you want to read the study itself, you definitely can. But they actually talk about having, for like implementation, having newsletters to share like monthly updates and talk about the rates of postpartum hemorrhage that they're having, transfusion, and basically how the implementation is going. Have champions like midwives and doctors oversee the change, because change oftentimes comes best from within rather than dictated from on high, right? People would always typically rather be a part of something and help move something forward rather than be pulled forward against their will, right? And so if you have somebody at each level being a champion of the team, really supporting it from within, a lot of times you can get a lot better success. But then you'll also be able to figure out the problems that need to be troubleshot in the meantime. My favorite is when somebody who no longer works at bedside decides what's going to solve the bedside problem, but they just have a fundamental lack of understanding of what the problem looks like because they haven't had to deal with it. And so some of my favorite inventions and like solutions for things have been from what seem like menial levels of the team. And it kind of goes back to the idea that there's no such thing as a menial job, only menial mindsets, right? Everybody's a part of the team that's going to help make this successful. And so making sure you have champions at all levels of the team can be really helpful. In the trolley or carrying case, right, the idea of restocking everything to make sure that you have everything you need to execute your plan. And then training, this again goes to, we kind of fall to the level of our training rather than rise to the level of our education, right? You need to practice this. You need to be familiar with it. The other day we were doing a thoracotomy and we were going to try and take the sternum, and I couldn't remember the name for the dang thing that you hold that's got like the blade on it to hit through the sternum. And so if I don't remember the tool to call for, it's going to be really hard for somebody to get me the tool, right? Or that my team knows the name of it, right? You might know the name of that fancy surgical tool named after some person who died long ago, but if your team doesn't, it doesn't matter if you called it by the right tool if you can't actually acquire it. And so making sure you're working well as a team, right? One of the things, the fears I have, and the thing that kind of drives me nuts with some of these really high risk, high stakes, high acuity situations is people keep coming in, right? So traumas, you might be there and then surgery team arrives and things might get like bumped up, and then OB arrives and things, and then every time you're introducing a mess of new people factors and new information and lack of information and new teams. And so knowing how to work with each other, right? So when does the handoff happen? How does the handoff happen? When do you step away because you've now handed off? Do you need somebody to stand around? So like if OB were to come down to rescue me from this, they don't know where anything is, right? They don't know where all of our like massive transfusion lines are or how to get blood down there or things like that. So if I just say, sweet, OB's here, I'm going to go check on my other patients, now I've left them out to dry, right? So making sure you're actually practicing these things with each other. So one of the things we've really started implementing is in situ simulation. And so we'll run a simulation in the space in which we work in order to make sure that we actually know how to execute it outside of our training space. Yeah. Another thing that can work really well in certain settings, depending on where you are, is the Bakri balloon. Let's see if this will work when I try and open it here. And let me know if you can see it, because with screen share, it also might not cooperate. This button.
The first step is to place the Bakri
Hold
balloon.
on.
I'm going to gently insert through the vagina, through the cervix, and into the uterine cavity. There are two ways to fill a Bakri balloon. This is the manual way. Draw up 50 milliliters of sterile saline. As my assistant is instilling the saline, I'm making sure that the Bakri balloon is still seated properly in the uterine cavity. Make sure that you turn the stopcock. If you
We'll stop sharing for just a second here.
fit in the basin of water. This here is a
I opened it in a new tab, and now I don't know which tab it opened into. But it's also playing in the background, so as soon as I turn the sound back on, you'll get an earful of it.
the manual way. Draw up 50 milliliters.
I found it. Okay. All right, can you see the video? Okay. I apologize. It actually has kind of gross sounds, but it explains the procedure well. So the idea is, how do I get pressure on the inside of the uterus when I can't necessarily know which part of the uterus the bleeding is coming from, or see if I'm actually applying the pressure well. And so one thing that was derived is what's called the Bakri balloon. And this is almost kind of like a Blakemore, but for the other end. And so the idea is you're going to insert it and then inflate it to provide tamponade, or to provide like outward pressure to help you try and tamponade the bleeding. And actually, one of the MRAP cases that was on probably about 2 months ago was in the rural United States, and they ran into severe postpartum hemorrhage and they didn't have OB-GYN in-house. So they actually used a Bakri balloon in order to stabilize the patient for transport to a center with the appropriate staff. So here we go. Can you hear it?
The first step is to place the Bakri balloon. I'm going to gently insert through the vagina, through the cervix, and into the uterine cavity. There are two ways to fill a Bakri balloon. This is the manual way. Draw up 50 milliliters of sterile saline. As my assistant is instilling the saline, I'm making sure that the Bakri balloon is still seated properly in the uterine cavity. Make sure that you turn the stopcock. If you do not, the liquid will drain out. The faster way to actually instill fluid into your Bakri balloon, take the accompanying tubing and spike an IV bag. If I don't have an IV bag available, I can actually use that tip and just place it in the basin of water. This here is a one-way valve. And then using the same 50 ml syringe, we're going to connect immediately to the device. And that should automatically draw up your fluid. As soon as she is done drawing up, she can go ahead and instill without actually separating the syringe. And you can see now the fluid is going directly into the Bakri balloon.
Could y'all hear that okay? Okay. So one of the things that I find interesting about that, or that I want to think about when I think about that procedure, is I try to be just in my interpretation of things, in that I try and treat numbers I don't like the same way I treat numbers I do like, right? If I'm gonna dismiss the bad O2 sat because I think, oh, it's got a bad pleth, I need to similarly dismiss the good O2 sat that's got a bad pleth, right? And so I try to make sure I'm being kind of cognizant on both sides of the spectrum when I'm implementing tools. And so what's one of the big things that I would want to be cognizant of or cautious of when implementing a Bakri balloon? And it's a bit of a guess what I'm thinking question. I apologize. Try to avoid those. I'm really bad at it. So for me, one of the things that comes to mind is, how do I know that it worked, right? And so the idea that if I've now inflated a balloon in the uterus and I put in and it might say on the instructions on how much to put in or whatnot, but there's variability depending on how big the uterus is and whatnot. But so let's say I put X amount in there and I no longer see blood coming out of the vagina. How do I know I've actually stopped the bleeding versus just masked the bleeding? And so something you want to think about before you go into this is, what are your endpoints? Is your determination going to be, I'm going to determine if this worked by vital sign changes? Is it going to be, we're going to be doing something with ultrasound, or is it going to be an empiric treatment where I'm going to place this, transfuse, transport? So think ahead of time what you're actually trying to accomplish with that and how you're going to measure whether or not you've accomplished that goal.
Nick,
Yeah.
Nick, is uterine rupture a risk at all with using the tube?
That's a great question. I suspect it might be a risk. I would suspect it would be low risk. As long as I imagine there's a predefined, can y'all hear me okay? Okay. I see Mohammed in the chat. Can you hear me now, Mohammed?
I can hear you all right.
Okay. So I suspect that there might be a risk with it, but there's probably, as long as you stay within a pre-specified margin of volume, it's probably lower risk. But to be honest, that's me speculating, not me knowing. Yeah. And it would probably depend on the pathology in which you're treating. And like, so for example, I would imagine the risk could be different if somebody's had multiple C-sections in the past, or they might have weak spots in their uterus, age dependent, and other comorbidities, like if they had like Ehlers-Danlos or things like that. But I'm entirely speculating on that.
And if you don't have this specific device, is there anything else that would accept 50 cc's that you could use alternately?
So I think they're doing 50 cc increments. I'm not sure it's a total of 50 cc's.
Okay.
But I think you probably could. I don't know. I think it probably depends on how bad your need is, in that, if I had nothing, I'd have to ask myself, would I try a Foley balloon? Would I try a Blakemore? But I don't know that. And so that would be one of those conversations I'd want to have well in advance on how I want to navigate that. Yeah. Gary, do you have any thoughts on that? I want to respect.
Yeah, I knew Dr. Bakri. He worked with us at Geisinger. What a wonderful, wonderful man.
Introduce yourself so that
Oh,
you know.
I'm Gary Stoner. I'm a retired OBGYN doc, and I am listening with quite interest to this entire thing as I look at this from an obstetrical perspective. I I think the thing to understand about a Bakri balloon is that it is a temporizing intervention. We are not fixing the problem. We're sort of staving it off until we can find out what's going on. The irony of a Bakri balloon is that when you have uterine hemorrhage, you want the uterus to contract. So what are we doing? We are putting a device in the uterus to expand it. So it sounds counterintuitive to do that. That's why I consider it a temporizing form of management, which is useful to get that patient into the obstetrical unit so we can find out exactly why that uterus is bleeding. I have personally never used a Bakri balloon. I've always questioned, you know, it seems counterintuitive to what we really need to do, but people have used it, and I think if you have to stave off the bleeding until you can find out what the actual cause is, that's really its utility. It's painful. When you put something in the uterus and expand it, that is going to be very painful for that patient. So they're going to need to be sedated somewhat, and just getting through the uterus, the cervix itself is can be a painful endeavor. So in theory, you know, it sounds good, and I think there is a utility for the Bakri balloon, but I think it needs to be understood that this is not a fix for the problem. This is temporizing until you understand why the you know, what's really going on. If you'd care to, Nick, to back up to that case scenario, I could give you my thoughts on what you had described there. You know, when I look at this from an obstetrical standpoint, my first thought is you see bleeding coming out, but where is the bleeding coming from? And it's basically the vagina, the cervix, or the uterus. To me, the first thing to do is to understand sort of what happened at delivery with this patient. If you're being told it was a forceps delivery or a vacuum cup, we have a little bit higher chance that we might be dealing with a vaginal source of bleeding. She's a prime-ip because this is her first pregnancy. Does she have a cervical tear? What's going to tell you that is that the bleeding is more likely to be bright red arterial rather than a darker bleeding. And then thirdly, is the bleeding coming from the uterus itself? The first thing you really have to do in a scenario like this is get good visualization, which can be difficult to do in an emergency room setting. You need stirrups, you need good traction to be able to visualize that, what's going on, and good lighting. Because progressing from this point is identifying the source of that bleeding. I've been in these situations, and it can be very difficult. So, you know, if you're trying to use a Bakri balloon for a cervical laceration, it's not going to work, or a vaginal laceration. So good visualization is really, really critical to examine this. I would say on average, the source is most likely to be coming from the uterus itself. And to know from a patient like this, has her membranes been ruptured for a long period of time, which could add to retained products of conception? Is the cervix open? An open cervix with bleeding would suggest more retained products. If I were to come to the emergency room to see this patient as you're describing and the cervix was open, I would take some ring forceps and gently explore the uterine cavity to see if I could extract any tissue, and then an ultrasound to see is there any retained products. That's, to me, the most likely thing that the etiology of the bleeding. She has a little bit increased heart rate. Her temperature's okay. She's satting good. And, if this woman had delivered in our institution, I'd want to know what her hemoglobin level was, how much sort of buffer we have to understand how much she might be, what margin of anemia we might be getting into. Because as you very aptly described, the estimation of blood loss is all over the map. And you only know once you get a hemoglobin how bad things possibly could go. So
I have a question.
yeah.
So my question for Gary is, for those of you that are on the front end of this, and you do go in and kind of clean out, and you don't see any active bleeding in the vagina or from the cervix, is it reasonable to sort of go into the uterus and try to find that plane, and if there's any retained tissue at this point, kind of scoop out to help control?
I have certainly done that at the time of delivery when the cervix is open and the baby just comes out. You can get your hand in there and do, put a gauze around your hand and sort of swipe that uterus. But we're what here, 2 days after delivery, I think.
This is 1 hour after.
Oh, 1 hour.
It was 2 days.
Yeah. Explore that with your hand. I've certainly done that. You can sort of tell we take the placenta after delivery and you sort of piece it back together when it's laying in the dish to see if you can see that it's not complete. That's usually the most likely reason for postpartum bleeding, is some type of retained products of conception, as we say. Putting a Bakri balloon in there is going to temporize that, but not it's not going to solve the problem.
From personal experience, as a trainee and as an attending, you often read about, go in there and find the plane, they call it the plane, and kind of separate the product of conception that's left over to control the bleeding. And I will tell you, I've had one case in my 30 plus years, and you can actually feel that plane. I was really surprised. It was not as hard as I thought it would be. I had a Amish woman who came in with a postpartum hemorrhaging, and was able to kind of get that under control by getting the last of the products of conception out of the uterus. And it is not as hard as you think it is to find that plane and just kind of move that material out.
Interesting. Thank you so much for all that. It's super helpful. Oh, welcome back, Jess. Yeah, and I'm also curious, just out of my own selfishness a little bit. How do you interpret that first hemoglobin? Because a lot of times I think of the first hemoglobin as kind of like my benchmark to compare with later, but oftentimes, especially if I'm worried about blood loss, I'm transfusing before I even know what it is, with the idea that sometimes it can take a while for the concentration to equilibrate. And so even if you have a big blood loss, you might not have a drop in hemoglobin right away. How do you interpret that first hemoglobin?
Yeah, that's a good thing, because there's expansion of volume, and most women will look anemic. I sort of flash back to med school in my training that said you treat the patient, not a lab value. Yeah, it takes time, very aptly, as you say, Nick, to equilibrate. Most women who are delivering have hemoglobins in the, 10-ish, 11-ish range. If something comes back at 7.2, you've had some significant blood loss somewhere, but it could come back at, 9.8, which is sort of normal, but it just depends what happens after that point in regard to, how much they continue to bleed.
Mhm.
I
But,
just.
but how far do you recheck it? So like, let's say
I'm
the
sorry?
first one's fine. So like, let's say the first one post-delivery is fine. Do you check another one in an hour, in 4 hours to see if that drop happens?
Well, typically we always just check the hemoglobin the next day, but if they're continuing to bleed, yeah, probably within a couple hours, I would check another one.
Sure.
But if a woman who just delivered a baby is continuing to bleed 3 and 4 hours after delivery, there's something wrong.
Yeah.
And you got to identify that cause, which is basically, is it vaginal? Is it cervical? Is it uterine?
Mm.
And job number one is getting really good visualization, which takes, basically, and the operating room, getting them up in stirrups, lights, and equipment, which can sometimes be difficult in the emergency room. But you got to find out the etiology of the bleeding before you can adequately treat that patient.
Sure. Well, thank you so much. I could pick your brain forever, but just to make sure I'm not being too selfish with your time, we'll keep moving here.
Sure.
Also, I find it hilarious to talk on the Bakri balloon and Dr. Bakri. But yes, I think that's and you bring up the good point too of that's a temporizing measure. So when I heard about that MRAP case of using the Bakri balloon, I was like, oh shoot, where do we keep our Bakri balloon? Turns out we don't have one. Why? Because we have OB in house, right? It's a temporizing measure until you can get them to OB in the OR, which we have here, right? And so if my plan is okay, patients here, I need a Bakri balloon. Well, my plan's already going to fail because A, I lack the resources, and B, it's a temporizing measure when I'm already at the definitive location. But awesome. All right, so next case. This will be a little more straightforward of a discussion, but a 20-year-old female has an elective C-section at 39 weeks at the end of her first pregnancy. There were no complications noted with the surgery. Baby is doing well. 2 days after delivery, you are called by the nurse because the patient is having abdominal pain. The surgical site appears well healed, but there's foul-smelling vaginal discharge, and her lower abdomen is tender to palpation, more than you might, kind of suspect at 2 days out. Vital signs: a heart rate of 120, blood pressure 90/56, temperature of 40 degrees Celsius, respiratory rate of 22, oxygen saturation 96% on room air. So what do you think the diagnosis here might be? It could certainly be more than one thing, but there's one we're kind of trying to point you to. Septic shock, definitely something to be good to be thinking about, for sure. Thanks, Boopa. Another one to consider on there, which is almost could be a precursor to that, is endometritis. So this is a bit of a generic term that we're using in a bit of a specific context. So endometritis is by definition is inflammation of the endometrium. And in this setting, we're talking about it in the postpartum setting, not chronic inflammation or things like that. But in this setting, a lot of times what you'll hear is about 48 hours after delivery is when you start to see some of this. And one of the big risk factors they talk about is a C-section. That's not to say all C-sections get it, but the kind of like classic textbook scenario that they describe is you'll have a patient 48 hours after delivery via a C-section, and they'll have foul smelling lochia, abnormal tenderness palpation of the lower abdomen around the uterus, and fever, which, to be fair, right, I would imagine a lot of people who had a surgery and just delivered a baby are going to have might have some tenderness, and so you got to kind of take it in the context of the patient, but they shouldn't have a temperature of 40 degrees Celsius, if all things are going well, right? And if you have pus draining from the surgical site, that might point you a different direction. but prolonged rupture of membranes, prolonged or premature rupture of membranes, prolonged labor, frequent cervical checks. This is actually one of the things I remember them talking about in medical school, is just kind of the balance of service versus education and patient harm, right? So you want to learn how to do cervical checks. Getting practice on that is important, but the more cervical checks you do, the higher the risk of infection and complication. And so that's something to be really cognizant of with your patients, is how many cervical checks that they're getting. You know, do them when indicated, but also be cognizant on how many you're doing. Or known infections, right? If they're known to be colonized with GBS, they have chlamydia, HIV, the risk goes up. So the workup I thought was kind of interesting. And the research I was doing on it is there's not a lot that's super helpful from a workup perspective. So ultrasound, they said, didn't have great test characteristics, because a lot of times the findings on ultrasound might be similar to what you would find in normal postpartum patients. CT scan isn't definitively helpful all the time. They talked about blood cultures or endometrial cultures. They said these oftentimes aren't notably helpful because you want to start treatment before they would result anyways. And the likelihood that it's going to change your treatment regimen is often very low. And so they also describe these as not definitively helpful, because they want you to treat this largely as a clinical diagnosis. So if you have a recent post-op patient about 2 days out, oftentimes with a fever, abnormal uterine tenderness to palpation, and that purulent or foul smelling lochia. I always find it interesting when people describe some of that stuff as foul smelling. People say like foul smelling stool or things. I'm like, I wouldn't expect it to smell great, but something that stands out as abnormal to you, that's when they want you really thinking about this. And Booba's right. Like, one of the complications of this can be sepsis. It can also have adhesions or septic pelvic thrombophlebitis. And unfortunately, the treatment actually seems quite straightforward. IV clindamycin and gentamicin. They talk about you can consider ampicillin if there's, based on the resistance patterns in your area. And you treat with IV medication until the fever breaks and they're fever free for about 24 to 48 hours. And interestingly, oh yeah, Deb, great question. Do you guys have access to clindamycin and gentamicin at your guys' institutions? Uba, do you know if you have access to both of these?
Go ahead and unmute and just if you want to answer, just go ahead and unmute and shout it out.
Balu in the chat says we have them at sorry, I always pronounce it wrong. Embarara. That's cool. Do you know if that's the usual regimen you use there based on resistance patterns? I recognize that depending on where you work, that might not be the most frequent thing. So like I've never treated this in the emergency department. Because there were some other options it did talk about, and especially depending on what antibiotics you have available, they might be narrowed down to be more specific there. Okay. So clindamycin might not always be available. Okay. I think one of the other options it said we could do instead of clindamycin, I think you could do Unison and metronidazole, ampicillin, sulbactam. And so this is one of those ones, I think, Mohammed, you bring up a great point, is what resources do you have and what are you going to do based on those resources, right? So this is having that plan ahead of time. All right. Thanks for coming. And so what are you going to do ahead of time in order to make sure that you can treat the way you need to treat and you know the plan? But they found that if you've treated, you have ampicillin and gentamicin. Okay. They say treat for 24 to 48 hours after the fever breaks, and they actually found that there was no significant benefit to, once the fever breaks on the IV antibiotics, to transitioning to oral antibiotics. They said you can just current recommendations are you can be done with antibiotic therapy at that time. All right, so we'll move on to the last case here, on the last section. So it's a 23-year-old female who presents with 1 week, presents 1 week after delivering her first child, after her first pregnancy, for a severe headache. She had routine prenatal care and has no other known past medical history. The headache started today, and she's also reporting blurry vision. Her heart rate is 90. Her blood pressure is 166 over 112. She's afebrile. She's not tachypnic, and her oxygen saturations are good. And just for efficiency, we'll kind of move through here. What we want you to be thinking about is postpartum preeclampsia. So one of the things that I didn't know until embarrassingly late in medical school is that this can happen after pregnancy. I remember I was actually had like 2 months left in medical school, and I was helping teach a paramedic program, and we were going to do scenarios. She's like, all right, your scenario is postpartum preeclampsia. And I'm like, wait, what? That's a thing? Right? Like I had no idea. And I was like, preeclampsia, the treatment is you deliver the baby. Then your problem is solved. Like this is behind you. And boy, was I mistaken. So it's thought to be due to abnormal placentation and maternal systemic vascular dysfunction. But basically, it's multifactorial. It's a problem with the placenta and the maternal system, or an abnormality, I should say. It's diagnosed after 20 weeks of gestation. It's usually there's a list of criteria that are usually pretty readily findable online, but the two main thoughts are new onset hypertension and proteinuria, or new onset hypertension and significant end organ dysfunction, because they recognize it can happen outside of the setting of, there's not always proteinuria, even though there usually is. They talk about blood pressures of systolic 140 or greater and diastolic 90 or greater, and they want it on 2 measurements separated by 4 hours. And this is one of those times where it's really good to make sure you're actually getting a good blood pressure, right? If somebody walks in and sits down and their blood pressure's high, maybe it's because they're pregnant and walking and it's hot out, not necessarily that they have preeclampsia. So that's part of why they want you at rest in between these 2 blood pressures. My last doctor's appointment, they're like, oh, you have high blood pressure. I'm like, no, I was sitting comfortably in a chair until you called me back, and I lifted my 20-pound backpack and walked quickly back to the room where you had me then take my blood pressure. When the doctor came in and checked it 20 minutes later, it was fine, right? So our bodies respond to our environments. But one thing that surprised me is that some data suggests that approximately 90% can be diagnosed at 34 weeks or later, including after birth. And that definitely was a surprise to me. And so then there's also preeclampsia with severe features. So this is the blood pressures, potentially 160 systolic or higher and diastolic of 110 or higher. And again, you want it on 2 separate measurements. But then severe features of, for central nervous system, a severe headache or vision changes, liver dysfunction, like your transaminase is doubling, or persistent severe right upper quadrant epigastric pain, low platelets, elevated creatinine or a doubling of your creatinine, and pulmonary edema. So this can actually present, commonly 2 days, but up to 6 weeks postpartum. And so it's not necessarily common at 6 weeks postpartum, but this is what we're kind of saying, where we want you to be thinking about this farther out, because what we don't want is you to miss something that's really has a high level of impact on your patients that's treatable. It was posited that 11 to 44% of preeclampsia cases in one study presented postpartum, which again just blows my mind and seems a bit drastic, but at least paints the picture that we got to make sure we don't miss this. 70% of patients that presented with postpartum preeclampsia in one study presented with a headache, and 20 to 30% had some signs of pulmonary edema. So for treatment, you want to focus on blood pressure control. So some of the main medicines you use are labetalol, hydralazine, or sometimes nifedipine. And the goal is you don't want to decrease it by more than 25% in the first couple hours. And Gary, I'm curious for your thoughts on this. I think of this as kind of a form of hypertensive emergency, where you don't want to drop it too far too fast, but you want to make sure you start getting it down. What are your thoughts?
Yeah, you certainly don't want anyone to stroke. Boy, I have to say, Nick, I find it interesting that those numbers are so high. Those percentages sound really high to me for
I would have guessed
postpartum
under 2%.
preeclampsia.
Mhm.
I have to say I'm struggling hard to remember seeing this.
One of the studies might have been biased by, I think it was those presenting to the emergency department, which again might be skewed because a lot of patients, it might be a selection bias there too.
Did you usually give magnesium?
Yeah, we certainly gave magnesium, during when they're still pregnant, you don't want to decrease it. fast,
Mhm.
because then you'll decrease the, the pressure across the placenta to the baby as well. But postpartum, yeah, I don't know how sensitive you could monitor, that decrease.
So you're saying postpartum, you can go a little faster,
I would
bringing it
think.
down?
I've never been, to be honest, I've never been involved in a case having to do it postpartum. But you certainly have to go slower when baby's still in utero.
Sure, sure. No, I'm also curious because to me the answer to this is like immediately discussed with OB-GYN, right? And if I have severe features, I'm happy to give magnesium. Like I can't remember a time where I was like, oh crap, I need to watch out for like giving to like I watch out about giving 2 to 4 grams. In this case, I think they talk about 4 to 6 grams of magnesium.
Yeah.
But on up to date, literally in like letters is like for postpartum preeclampsia, it literally said no evidence-based standards for the optimal approach to postpartum maternal monitoring and follow-up have been established.
Yeah.
I wasn't
But
sure.
I think Nick, I think your point is well taken. Even once baby is delivered, you just treat mom like you would any other hypertensive patient
Yeah.
and not drop it too fast.
Yeah. But so I just thought that was interesting is it's something I'm hearing about more and I'm clearly late to the game and kind of learning things here and there. But I was surprised that there hasn't been like, oh, here's our goal of this, and this, or here's, our direct admit or, things like that. But so that kind of brings us to the end. So with postpartum hemorrhage, I want to talk about having a standardized approach, right? The emotive approach could be a really good one for you, but make sure whatever approach you have, you discuss it with your team, you make sure it works for your context and you practice it. For endometritis, we want to really focus on it being a clinical diagnosis and your antibiotics, right? So look for that fever, look for that abnormal tenderness and that abnormal lochia. And then clindamycin and gentamicin plus minus ampicillin. But make sure to be respectful of your area's biogram, right? Like what resources do you have for your antibiotics and what works well in your region? And then postpartum preeclampsia, make sure you don't miss it just because the baby's already been delivered. And some of the good medicines to use are labetalol and hydralazine to get that blood pressure down. Don't be afraid of magnesium, especially if you have severe features. It's a very safe medication. And definitely talk to OB-GYN about what your next steps are going to be. So thank you so much. And if we could fill out, use the QR code, fill out the survey. I think Deb has put in the chat here. But then also here's a QR code for you as well. It'd be super helpful.
Thank you, Nick. And thank you everyone for joining. It's really nice to meet all of you and see your interest in this. It's been a fun discussion.
Mm-hmm. Yeah, thanks for having me.
Yeah, thanks for coming.
All right, take care, everybody. Be well. Thank you for the jobs you do. It's not easy.
Yeah, thank you.
Great, Nick. Thank you so much. It sounds like it was a really passionate able to participate. It seemed like you're amazing. Thank you.
Oh, thank you. Definitely had some awesome help.
Thank you.
Jess, okay to end the meeting for all?
Yep, I'll go ahead and oh yeah, you
Bye, everyone.